All right, good morning, everyone. So we're starting this non-invasive cardiovascular imaging fellowship boot camp with this lecture about stress testing, ECG interpretation, and stress lab emergencies. My name is Hicham Skali. I'm one of the cardiologists at the Brigham and Women's Hospital. I have no relevant disclosure to this presentation, but these are my disclosures. So let's start by talking about physiologic responses to acute exercise. And I'm sure you're familiar with this, but when you start exercising, be it on a treadmill or a bike, there are a variety of things that starts happening. And initially, your vagal tone will increase while your sympathetic tone will start to rev up. This will lead to an increase in your heart rate and stroke volume, the product of which leads to an increase in the cardiac output. And this is essentially to have an increase in your myocardial oxygen. This is essentially because you have will lead to a myocardial oxygen demand, which will need to be matched by an appropriate supply in your coronary blood flow. And it's not just in the coronaries, but also peripherally to have appropriate delivery of oxygen to your peripheral muscles. And so if we were to list the normal responses stress testing here on the left side of the screen, you'll see that, as we mentioned, the heart rate has to increase, the blood pressure will increase, cardiac output also will increase as a consequence, and also total peripheral resistance will decrease. You might have some minor and benign arrhythmia, such as isolated unifocal PVCs and PACs, and often these are increased at a higher heart rate because those ectopic foci won't have time to fire up once you have a much faster sinus rhythm. And also, as we mentioned, the oxygen consumption will increase. Some of the abnormal responses to stress testing or to exercise, and those are things that we are concerned about and we watch for, is if the heart rate fails to rise above 120 beats per minute, or if you're unable to attain 85% of your AP-MHR. So that's an abbreviation for age predicted maximum heart rate, and that can be determined in a variety of ways. If you have a drop in your systolic pressure, that's also something that we wouldn't expect and we wouldn't want as well, and people who are physically unable to complete the test. Development of a marked hypertension, such as a blood pressure greater than 220 over 110, is also an abnormal response, and we would stop the test for that reason. And if someone developed a significant chest pain or unusual shortness of breath, that would be also a problem. People, when they exercise and they have stress testing, should not have these symptoms. So first question that I have for you here, and you can answer me in the chat box: which of these is an abnormal response during exercise? A, increase in heart rate; B, decrease in systolic blood pressure; C, increase in cardiac output; and D, decrease in QRS complex duration. Good, so I see a lot of responses for B, excellent. And so, yes, that is the appropriate, correct response. And so let's shift to talk about normal ECG response to stress testing. We talked about some of the general physiologic responses, but let's talk about the ECG responses. So some of the things that would happen is that the QRS complex will decrease in size. So its amplitude will decrease, but not only the amplitude, but also the duration of certain intervals, such as the PR, the QRS, and the QT intervals usually will decrease in duration and will become shorter. You will also notice a J point decrease. A J point is that part of the EKG, is the point in the EKG between the end of the QRS and the beginning of the ST segment. And that's a junction between those two entities. And during exercise, that J point will decrease below the PR baseline level. And this will lead to a upsloping of the ST segments. As the J point is lower, the ST segment will start to upslope to reach back that baseline line. And so the ST segment would only return to its baseline by about 80 milliseconds after the J point. So in a regular standardly scaled ECG, 80 milliseconds is about 2 little squares. So if you were to figure out where is that 80 milliseconds after the J point, first you define your J point, and then you go about 2 little squares after that. You will also see sometimes a downsloping of the PR segment. It doesn't mean that the segment becomes is depressed. It just has a downslope to it, and that's most often seen in the inferior leads. The R amplitude may decrease at rates greater than 130 beats per minute. The P wave amplitude will increase, and the T wave amplitude also decreases. And we're going to see these graphically here. So these are ECG patterns that you see with exercise, and we'll start from the top left. So at rest, you can. I'm going to define the different structures here. Here is a an entire cardiac cycle. Here you see a P wave, then the QRS complex. This point here is called the J point, right at the end between at the end of the QRS segment and the beginning of the ST segment. So this would be the ST segment, and this would be the T wave, and this would be the beginning of the TP. So in lead V5 here, you can see that with exercise, there is shortening or decrease in the amplitude of the QRS. We're not seeing several cycles here, but as I said, you will see a decrease in the QRS duration, a decrease in the QT interval, and that's all a consequence of the increase in the heart rate. The other pattern that we can see is a rapid upsloping pattern. And so here you can see the ST segment is relatively flat, but then you have it very quickly become upsloping here. And so if you were to see that the J point is about here, just say, you see the J point is about here. If you go to 80 milliseconds, which would be about here, you see that the J point, the ST segment is rapidly upsloping. Here you have minor ST depressions. Just in comparison to the PQ interval, you will see that there are minor ST depressions, but these are not consistent in the in over 3 beats. And also they are not depressed over 1 millimeter. This is the computer averaged mean. And you can see that the average is about minus 0.9, so less than a millimeter over there. There is slow upsloping ST segment here again, and you can see it only in this portion here. And these are not necessarily diagnostic. The thing here is that you can see them not in in more than 3 consecutive beats. And then these are what we call diagnostic ST segment depressions. Those are that are horizontal and downsloping. And you can see here these are fairly obvious. They last more than 3 consecutive beats. If you compare it to the PQ segment, these are over 3 millimeters here. And so this would be, and they are horizontal. You can see the slope here being at 0.0. And then you have downsloping ST segments, and you can see here clearly the slope is going down with ST depressions. And then you have what we call elevations in the ST segments. And there are 2 types of these. The first one is what we call ST segment in a non-Q wave lead. So you can see that on this lead, there are no Q waves. I mean, there is no evidence of a prior myocardial infarction. And then you can see that the ST segment is elevated here. It's elevated above the PQ segment. And that is diagnostic of myocardial injury. This is an indication to stop a stress test if someone is exercising. The other pattern that we see in which we can see ST elevation is elevation in a Q wave lead. As you can see here in this lead V4, you have a Q wave, and that could be suggestive in old lateral MI or anterolateral MI or a prior apical aneurysm, which you can see Q waves in V4 through V6. And with these, your QRS, as you know, represents depolarization of the left ventricle. And so just to make it simple, as the depolarization is negative, such as here, your repolarization becomes positive. So this is an exaggeration of your repolarization pattern that you can see in Q wave lead with this ST segment elevation here. All right, so these are not necessarily diagnostic of myocardial injury or myocardial ischemia. These are what we call ST elevation in the Q wave leads, and they are an exaggeration of the repolarization abnormalities. All right, and so these are just the standards for diagnosis in ST changes. So again, the guideline requires that you have 1 millimeter or greater of horizontal or downsloping ST segment depressions. They have to be present in 3 consecutive beats. These have to be compared to the PQ points, not to the TP segments, which comes after the ST. We usually see them at 80 milliseconds after the J point. And if there is an earlier repolarization, then compared to the isoelectric line, and I'll show you this on a schematic a little bit later. You have upsloping ST depression, especially if they are rapidly upsloping, such as here, there are rarely true positives. And then ST elevation, they have to be 1 millimeter or greater above the PQ points after, at 60 milliseconds after the J point. And again, they have to be seen in 3 consecutive beats. If they are in non-Q wave lead, as I mentioned, they would represent either significant coronary artery disease, and they are localizing, meaning if you see these ST elevations in the inferior leads, that means the stenosis is in the RCA or the PDA. If you see it in a lateral lead, it's more likely to be in a circ, and if you see it in the V4, in the anterior or anterolateral leads, they're more likely to be in the LAD. So ST segment elevations in a non-Q wave leads are localizing. They can also represent a spasm, and often you will see that if you have diffuse ST elevation, not localized. If on the other hand, as I mentioned, you have a pathologic Q wave that is present at baseline in your EKG, then that usually represents LV aneurysm or a baseline wall motion abnormalities, and these are not necessarily an ischemic pattern. This is if you have, as we mentioned, your ST segment does not start at the isoelectric line to start with. So let's say that at rest you have ST elevation. So the red graphic is your standing pre-exercise QRS. And so if at rest your ST segment is elevated, then you have to measure your ST depressions from the PR isoelectric line, right? So if this is the PQ point or the PR line, then you measure your ST depression from there. You don't measure the depression from the baseline or the starting ST segment. You measure it from the isoelectric line represented by the ST depression. Oops. If on the other hand, your starting EKG has ST depression to start with, then you measure your ST depression during exercise from the baseline or from the starting ST segment. So you measure it from between the red line and the blue line. All right, so there are some ECG abnormalities that can be there at baseline that may decrease your diagnostic specificity, and I'd like to review them here. First one is LVH with ST depression that are greater than 1 millimeters. And often, this is an example that you can see here. And usually this is a problem because if you're starting with greater than 1 millimeter ST depression, it is very likely, not always, but very likely that with exercise, you're gonna have an exaggeration of that response, and you're gonna have 2 to 3 millimeters ST depression with exercise. And then that's not very specific because you will not know whether that ST depression is due to ischemia or is due to an exaggeration of the repolarization abnormality that you have with LVH. A left bundle branch block pattern like this, which is going to be represented by a widening of the QRS greater than 120 milliseconds, mostly seen in V4 upward and with the positive deflection in V4 and V6 and negative deflection in V1, and often a slurred pattern like this one. You will see that when you see this, you cannot rely on the repolarization pattern to decide whether there is ischemia or not. So often you cannot interpret the EKG response to exercise when you have a baseline left bundle branch pattern. And similarly for ventricular pacing, like this, you cannot rely on the repolarization. So the context is that if your depolarization is abnormal, such as a baseline left bundle branch block pattern or ventricular pacing, your repolarization is also going to be abnormal, and you cannot rely on that to diagnose ischemia. Pre-excitation patterns, such as with WPW, here this is a schematic that I picked up. You have a short PR interval, you have a delta wave, that's where the signal goes through the accessory pathway. And again, this often leads to a wide QRS, and this is often an abnormal depolarization because you're not going through a narrow classical representation of your depolarization with through the AV node and the His-Purkinje bundle. Because you're going through an accessory pathway, your depolarization is abnormal, and often you're going to have abnormal STT wave changes, and so that's an abnormal repolarization that you cannot use to diagnose ischemia. A digoxin or digitalis effect, not necessarily digitalis toxicity, just digitalis effect. You can have this hockey stick appearance of the end of the QRS, the beginning of the ST segment, and this curvature here. There are a lot of nicknames for it. One of them is the Dali mustache here. You can see the similarity here. And because of that, again, you cannot use that reliably to diagnose ischemia on an EKG. And so these abnormalities are often more common with older age and comorbidities. And what happens is that they introduce some confounding because, as I said, they decrease your diagnostic specificity. It doesn't mean that you cannot exercise these people on the treadmill. It really depends on what is it you're trying to get from your exercise testing. So if you put them on a treadmill, you can help assess their exercise capacity. You can see if there is any arrhythmia provocation in their blood pressure response, and can you trigger their anginal pain again, if that was the question. So again, these baseline ECG abnormalities are not a contraindication to exercise testing. It just alerts you that you cannot use the EKG response to diagnose ischemia. Another question here that you can answer in the chat box, please. And so, which of these statements is true? Presence of a right bundle branch block precludes the ECG interpretation during an exercise stress test. Presence of a left bundle branch block precludes the ECG interpretation during an exercise stress test. Presence of a bundle branch block, right or left, precludes the ECG interpretation during exercise stress test. And presence of a bundle branch block, right or left, does not preclude the ECG interpretation during an exercise stress test. Some chat responses coming in. People are answering B, and that's the correct answer. Very nice. So yes, as I mentioned, left bundle, you cannot use the ST segment to diagnose ischemia. In a right bundle branch block pattern, you cannot use the ST segment in V1 to V3. You can use the ST segment changes in V4 through V6 and in the other precordial leads. So whenever you have, because in right bundle branch block pattern is mostly the V1 to V3 that the QRS is the most abnormal. This is an example of a left bundle branch block pattern. At rest, you can see there is already a widening of the QRS and an abnormal ST segment with a T wave, negative T wave. At stage 1, you can start to see some ST segment depression and persistent T wave inversions. At peak exercise, the ST segments are even more depressed. You can see it in V4 through V6. And even in recovery, there is persistent T wave inversions and a slight depression in the ST segment. Again, based on this, we cannot say that this stress test is positive for ischemia. What we would say is that because of the left bundle branch pattern, we cannot interpret the EKG, but we can give information about the blood pressure response, the exercise capacity, the peak heart rate attained, and so on. So let's shift gear and talk about complications and adverse events of exercise testing. So first of all, I'd like to alert you and make sure that you understand that this is usually a very safe procedure. We do dozens of stress testing a day in our lab at the Brigham, and we very rarely have any kind of complications or significant complications or adverse events. So this is one of the a very safe procedure. The rates of complications are extremely low. We're going to go over this in a summary of about 8 studies. The rates range from 0 to 5 per 100,000 tests. So you can see the percentage there, which is extremely low for sudden cardiac death. The rates of complication is about less than 0.2% for any kind of hospitalization. Acute MI less than 0.04%, and sudden cardiac death less than 0.01% there. Overall event rate of serious events is about less than 1 in 10,000, whether it's death or hospitalization. So again, you can see that those complications are quite low. And there are recommendations from the American Heart Association about how to be ready for this and how to keep those rates of complications low. And so one of the tenets of that is really proper risk stratification, proper selection of the patients you will allow to have your stress test. So not only the test is ordered by a physician or a PA or an NP or order this test, and so they do get some selection in that, but you in the stress lab will also have to risk stratify those patients and decide whether this is a low, intermediate, or high risk patient to figure out what might happen. So risk stratification of persons to determine the appropriate level of medical supervision needed during the testing. So usually our exercise physiologists, when they do the pre-screening and they look at the chart, they will actually figure out, oh, this is a low risk patient, they can do it. And then otherwise, oh, they can come to you and say, hey, Aldo, this patient had VT with VF, conversion to VF and cardiac arrest about 3 months ago. He had an ICD since then. And right now he's coming back for another test to see how he's doing. So, and his VT was while he was running on the treadmill or jogging outside. So you know that this patient had an arrhythmic event with exercise, so you want to be more cautious about him. And so what you would do when the physiologist comes to see you about this, you might suggest, well, I will be in the room with you. So you will have both the physiologist and an MD there in the room supervising the test. In our lab, we have a written emergency plan that is rehearsed regularly with our physiologists and all the personnel. And usually that means knowing where the code cards are, who will run the code, how the code will run, and so on. And so it allows us to really be ready, even though because these complications are quite rare, you don't want to be complacent and not be ready for them if that happens. We have external defibrillator and in our code cards and in each room actually. And then, as I said, the staff is trained to handle all these emergencies and recognize these abnormal hemodynamic and EKG and responses. So everyone who's in the stress lab is usually ACLS certified, and a supervising MD, attending MD who's ACLS certified has to be around as well. So the guiding principles that we have at the Brigham, I listed them here, but there could be generalizable pretty much everywhere, is to err on the side of caution. So always consider stopping the test. If you are concerned about someone having some arrhythmias, or their blood pressure going too high, or their heart rate going too high, or they're starting to have chest pain or lightheaded or dizzy or anything, it is always your first option to say, okay, do I need to stop the test? And if you're unsure, if you think, okay, this might be dangerous, just go ahead and stop the test. It's always, one could say that it's always better to stop a test early than too late. And if it's necessary, call a code. Don't try to manage things on your own if you know they're not going in the right direction. And when the code team arrives, you let them manage the situation. Always have in the back of your mind the bad, what I said, quote unquote, the bad stuff here. So left main disease, severe aortic stenosis, ventricular tachycardia. So always have that in the back. Someone might have non-specific or vague symptoms or vague findings, but always say, okay, well, could this be left main? Could this be severe aortic stenosis? And then another very important point that's relevant to everyone is to maintain proper communication with everyone, with the referring clinicians. So whoever sent you the patient to have the test, you want to make sure that they know what happened to their patient if something bad happens. And then you want to look also at your consequences. So if something bad happens in your stress lab and the patient is going to the ED, or you're going to be sending the patient to the cath lab, or you're going to be sending them to the cardiology inpatient service, you want to make sure you close the loop with, on the receiving end, who's going to be taking the patient, and tell them what happened and what you did in the stress lab with that patient. Always good to give context in that sense. So what are some of the adverse events or emergencies that could happen in the stress lab? And they're listed here. So this could be chest pain, significant ST segment changes, tachy or bradyarrhythmias, hypotension, syncope or falls. We can look at some of the effects of vasodilator agents, dyspnea or wheezing, and seizures. So let's start with the case. I chose to illustrate some of these with some cases, and we'll go through them. So first one is a 55-year-old female with known coronary artery disease, referred for evaluation of chest pain. She reported typical chest pain at the time of exercise, and at that time there was no diagnostic ECG changes. So what do? One, continue the test and repeat the ECG tracing. Patient is not at peak heart rate, so add regadenoson. 3, stop the test. 4, inject regadenoson and inject systemibine. And you can all again start answering in the chat box. All right, so this patient is having chest pain. You haven't reached diagnostic EKG changes, but she's having a relatively concerning chest pain. So what you would consider doing is actually stopping the test. And the reason is that if the patient is exercising and you are concerned about their chest pain, don't inject. Well, you could inject, but the main thing to say, okay, well, is we're gonna stop the test. Even if there are no EKG changes, typical angina should be viewed with appropriate concern. And then you would need to alert the referring physician and consider adding imaging or performing CT angiography if the patient is stable. You can inject the system-inhibitor tetrophosphine or whatever agent you have during the chest pain, but the main thing is to stop the treadmill if you are seriously concerned about that. You do not unhook the patient from the EKG machine. You continue monitoring their ST segments throughout the test and in recovery. And if the patient is hemodynamically stable, that means their blood pressure is okay, and they are continuing to have chest pain, you can give them some nitroglycerin if you have no other contraindications. And while they are you do that while they're on the stretcher. Don't give them nitroglycerin while they're still walking on the treadmill. The blood pressure might drop and you end up with a different kind of accident. So don't do that. And if the chest pain persists or worsens, even with repeated doses of nitroglycerin and beta blockers, or the hemodynamic status is compromised, then you might need to transfer the patient to the emergency room or to the cath lab directly. Next case is a 64-year-old gentleman with atypical chest pain. This is their baseline EKG. As you can see, there is a sinus rhythm with a normal axis, and there are no significant ST changes at baseline. They start exercising, and this is their EKG at 10 minutes and 13 seconds of exercise. You can see that there are some ST depressions here and here. They do not persist for three consecutive beats. You can see them here again in lead V4. They seem to persist for over 3 consecutive beats. And here is a blow up of that. If this is your PQ segment, you can see that the ST segments are depressed over 3 consecutive beats here. And at 1 minute in recovery, all of that has disappeared. See, there is upsloping, and by 80 milliseconds, it's already back to their baseline near the PQ segments. So the way we reported this test was, this was a positive test for ischemia, but with reduced specificity due to absence of anginal symptoms at high workload, 12 METs, and very rapid recovery of ECG abnormalities. So it's another concept I'd like you to keep in mind, is that what is the functional capacity the patient attains? So 10 minutes on a Bruce protocol is about 12 METs for this person. They had no symptoms during their exercise, and there was a rapid recovery of the EKG abnormalities. So while those ST changes in the beginning were diagnostic, you had greater than 1 millimeter ST depression, a horizontal ST depression in more than 3 consecutive beats. So that's diagnostic for ischemia, but the specificity is reduced because of these reasons that I just listed. And so in your report, you would say that. There's another case here. This is a 55-year-old gentleman referred for an exercise, maybe to evaluate for ischemia, and he had recently unheralded syncope, so completely unforeseen, out of the blue syncope. This is his baseline EKG. You can see here already there are some flattening of the ST segments. There are negative T waves in V3 and V5. And he starts exercising, and you can see at peak exercise, which is about 7.5 minutes, I think, for this gentleman, he started to have ST elevation. You see that this is a non-Q wave lead in V4 and V5, and you can see there are ST elevations that are not subtle. And so by the time the EKG, so what would you do? Sorry, here, another slide. So what would you do? Continue the test, repeat the ECG tracing, patient not at peak heart rate, add regadenoson, stop the test, inject regadenoson, inject the system-IB. But I think here everybody would agree that we would need to stop the test. So if you have significant ischemic ECG changes, whether those are ST elevations or ST depressions, what you would want to do is stop the test. Do not worry about injecting the tracer. Priority is about safety here. So as we mentioned before, ST elevations are localizing for ischemia. You ask the patient whether they have symptoms, chest pain, dyspnea, lightheaded, or dizzy. Continue monitoring the blood pressure and the EKG. You can give them sublingual nitroglycerin if the blood pressure is stable and they have no contraindications. You can give them a baby aspirin as well. Consider metoprolol or a beta blocker if they're not bradycardic and their blood pressure is stable. And again, this is an important finding. So you would need to call their primary cardiologist, the primary care physicians, or the emergency room if they were the ones referring the patient to you. And then you want to see, okay, where this patient gonna go? Is he gonna go to the cath lab? Is he gonna go to the cardiology or to the emergency room? So you would call them again. So you want to call whoever referred the patient to you, and you want to call and talk to whoever is gonna get the patient after you. So this patient we just mentioned was having ST elevation. Just before getting metoprolol, went actually into cardiac arrest. And you can see here that he went to torsade de pointe, and luckily we had just stopped him from the treadmill and put him on the stretcher. We were able to code him quickly and bring him back. And then he went to the cath lab, and he had a tight lesion in the LAD that you can see there. Here it is in a different angle, and he was stented and did well afterward. Another complication that we just mentioned is ventricular tachycardia, and this could be sustained or non-sustained VT. They could be polymorphic if they're ischemic related, and that can happen with either exercise or Dobutamine. So if you see VT, you just stop, again, you just stop the test. There is no, well, let's see if this persists, or let's see if this happens again. You stop the test. You assess the hemodynamic status. You can take your time to look at the EKG. Is this an artifact or not, and so on. But first you stop the test. And if it is sustained and the patient obviously is in trouble, then you start your ACLS protocol and resuscitation measures, right? So if someone is having VT and you're always worried that this might convert to a worse rhythm such as VF, and so you want to stop right away and take care of it appropriately. The other significant EKG changes that can happen is ST depression. This is a 75-year-old man who was referred for exercise tolerance testing for exertional angina. On the left, you have his baseline EKG showing sinus rhythm, normal axis, normal intervals, and relatively normal ST segments. And with exercise, you can see that he developed, again, ST depressions that are consecutive in over that are present in over 3 consecutive beats, both in V5 and V6. You can see them here as well. And so this is what we said earlier about the ischemic ST changes, whether it's for ST elevation or deep ST depressions. You stop the test if they are deep. I think in our lab, the recommendation is that if the ST depressions are greater than 3 millimeters, then you do stop the test. You don't wait for pain. If someone develops deep enough ST depressions, you stop the test. Okay, another adverse event that can happen is hypotension. And often these are related to hypovolemia, and they can occur early. They usually correct with when you give patients to drink, and sometimes they can be persistent, and the patients might need IV fluid boluses. You need to make sure that the patient is not does not have a cardiomyopathy, is not too sensitive to rapid fluid intake. If they happen late in exercise and they have associated ischemic findings, then they can indicate significant coronary artery disease. And you may administer IV fluid if you're not too concerned about the volume status. The other reason to be concerned with hypotension in the stress lab is aortic stenosis. So patient, as you know, with severe aortic stenosis might drop their blood pressure because of decreased cardiac output. So that's another reason to be careful. If you see hypotension with pharmacologic agents, usually that resolves when you stop the infusion. and you can give a quick, short, rapid IV fluid bolus, especially the IV is already in there. But again, you want to make sure that they're not volume overloaded, and what is their cardiac status in terms of cardiomyopathy. Syncope and falls, again, prioritize safety. So if someone starts saying, oh, I feel lightheaded, or I feel dizzy, or I don't have, you can notice that their balance is not great on the treadmill, you should stop the test. Then you evaluate the hemodynamic status. You can check blood pressure, check orthostatic blood pressures, and check on the treadmill while they're still on the treadmill. Make sure that they have no sustained arrhythmias. And use extra caution if they're on anticoagulation. So you certainly don't want someone who's on anticoagulation, be it warfarin or the direct oral anticoagulants, to fall on your treadmill in your stress lab. If they end up falling or end up hurting themselves, you want to assess and document any trauma sustained. So you make a quick, brief note in the chart that the patient fell and hurt their elbow against the treadmill ramp, or fell on getting on the stretcher and hurt their knee on the ground, or head trauma. And depending on the gravity that you see, you can consider referring the patients to the ED for further management. They may need head imaging if they hurt their head, and you always want to call, as we mentioned, the referring physician to let them know what happened to their patients. Let's talk a little bit about vasodilator agents. I'm not going to go into details about each particular agent, and there is another lecture specifically for that, but just to talk about some of the side effects or concerns that we might have with vasodilator agents. So regadenoson is a specific A2A adenosine receptor. It's a standard dosing. It's one syringe that has 5 ml, 0.4 milligrams. You inject it slowly over at least 10 seconds. The half-life, the initial phase has a 2 to 3 minutes half-life, and then there is an intermediate and final phase of up to 2 hours. There is a little schematic here from the ASNC practice statements that shows the protocol. You inject over 10 seconds the regadenoson, and then you follow it with the saline flush, and about 25 to 30 seconds later, you inject the radiopharmaceutical and you flush it afterward. Adenosine is also a specific adenosine, A2A adenosine receptor, but it can also affect A1, A2B, and A3 receptors, so it's less specific than regadenoson. It is a weight-based infusion over 4 minutes. Usually we use 140 micrograms per kg per minute. The half-life is actually less than 10 seconds, and so rarely requires reversal. The way we use it is you infuse it for over there are a few ways to use it. In this protocol, by the ASNC practice guidelines, it's infused over 6 minutes, and you inject the tracers at 3 minutes. In our lab, we infuse it over 4 minutes, and we inject the tracer right in the middle at 2 minutes. Dipyridamole is another agent that's less used in our lab, but still used elsewhere. It's an indirect coronary vasodilator. It increases tissue levels of adenosine, essentially, and then has the same effect as the adenosine. Its peak vasodilation is on average at about 6.5 minutes after the start of the infusion, and the tracer is injected 3 to 5 minutes into it. The half-life is about 30 to 45 minutes. It's also a weight-based infusion of 0.56 megs per kg, and it's injected over 4 minutes. And often, because it lasts for long and is less specific, it would require aminophylline to be reversed. Another agent that's not a vasodilator is Dobutamine, and we might use this in our lab, in the nuclear lab, for patients in whom we cannot give vasodilators such as adenosine and regadenoson. They have active COPD or allergic reactions, and we are concerned about vasodilator, and they still need a pharmacologic test then we could use the Dobutamine. Some of you also might be supervising the labs, and in the same lab we do stress echoes, and we could do the Dobutamine stress echoes, and so you might be required actually to supervise and provide this Dobutamine based stress test. So as you know, Dobutamine is a synthetic catecholamine stress agent. It stimulates both B1 and B2 receptors, and there is a dose-related increase in the heart rate, the blood pressure, and the contractility. The half-life is relatively short at about 2 minutes, with an onset of action within 1 or 2 minutes, but sometimes it can take up to 10 minutes to its peak effect, and it's not always predictable when the peak effect might happen. We usually start, it's a weight-based infusion and weight-based dosing. We usually start about 5 to 10 or 10 micrograms per kg per minute, and then we go incrementally from 10 to 20 to 30 to 40 micrograms per minute, and we do that depending on the lab protocol every 2 or every 3 minutes. There is some variability in there based on the lab protocol. And the target there is you keep going up until you reach 85% of the age predicted max heart rate. And once you reach that, then you need to you can inject the tracer, and you keep the Dobutamine going for another minute after you inject the tracer. It is possible that you may not reach the max heart rate with Dobutamine, and you might need to get atropine for a little bit of a supplement, a little bit of a boost to get that max heart rate. Just make sure you have no contraindications to atropine before you do that. You heard me mention Aminophylline. This is the reversal agent. It's a non-selective adenosine receptor antagonist. You would give about 1 to 1.5 meg per kg. The vial has about 250 micrograms, and depending on the body size, the patient's weight, you might give as low as 50 or 75 milligrams, or as high as 100 to 125 milligrams. And you inject it slowly by hand over 60 to 90 seconds. With adenosine, or with regadenoson, but you can see some heart blocks. This is an example that you can see here on the pre-test EKG. You can see there is normal conduction and a normal sinus rhythm. During the test, you can see that you start seeing some blocked P waves there, non-conducted P waves with the blue arrows. You can see that tends to persist. But then as soon as we stopped the test and the infusion was completed, normal conduction was resumed. So you could have some AV block with infusion with the vasodilators. You can see that with adenosine, sometimes more often with Dipyridamole. You may continue the infusion if the AV block is not persistent and is well tolerated. Sometimes if you have the patient move their hands and their legs and their ankles and their knees, flex their knees or ankles back and forth, they may overcome that AV block. You have them hand grip, you have a squeeze ball there that you can see. And there are some protocols and some labs where we do low level treadmill exercise during the infusion, and that can improve the tolerance of the dilators. Essentially, as you are active, you increase a little bit of your sympathetic tone, and so that may overcome the AV blocking agents of the vasodilators. If the AV block persists or becomes symptomatic, then definitely stop the infusion. And if you're using regadenoson or Dipyridamole that might last longer in the patient's metabolism, then you can use Aminophylline to reverse it. It's almost never necessary to use Aminophylline with adenosine because it has such a short half-life. These are the indications for reversal of vasodilator infusion. So if someone develops severe hypotension, their systolic blood pressure goes below 80. If they develop symptomatic, persistent second degree or complete heart block, if they start wheezing, if they have severe chest pain associated with acid depression of 2 millimeters or greater, if there are signs of poor perfusion, so pallor, cyanosis, and cold skin, And if there are technical problems with the monitoring equipment, so if you cannot monitor your patient, then you have to stop the test. And if the patient requires to stop, then you actually have to stop it. Dyspnea and wheezing with vasodilators. So albuterol via nebulizer. You can send them to the emergency room. But the best way to avoid this and to manage this is to beforehand you screen for active airway disease before the procedure, right? So if they have active wheezing, if they recently have been on a burst of steroids, if they have increased the inhaler usage recently, then likely they might be in the midst or just recovering from a COPD or asthma exacerbation, and so you don't want to be giving them vasodilator. You would increase the risk of having complications here. There have been reports of seizures with regadenoson and also with other vasodilators. And so the concept there is that regadenoson might lower the seizure threshold. And so what we do, you would screen for a history of seizures and active seizure medications, or if they have recent breakthrough through their medications. And in that case, you would not give them regadenoson. And what you need to know is that it's not because you have a reversal agent that you can use it in terms of seizure. Aminophylline itself can also provoke or worsen seizure activities. So you could use it, but you gotta be cautious about how and when. Usually you would follow the classical management of seizure, meaning you would give them benzodiazepines. If they're tonic-clonic seizures, you would put them on the side and use the usual protections, stabilize the patient, and you might need to transfer them to the emergency room. Call their neurologist and their primary care physician again to inform them, hey, the patient has a seizure in the stress lab. It's not always the most pleasant call, but you still need to do it. As I mentioned, the seizure risk is also listed on the package insert of adenosine and dipyridamole. Adenosine has a shorter half-life and may be preferred in that situation, but we would try to figure out an alternate test if possible. And so in all of these adverse events or emergencies, what I'd like you to remember is that you have to go back to before the test happens. How do you select your patients, who you allow to have the test and not? And so these are the commonly listed absolute and relative contraindications to have an exercise test. If someone had an acute MI in the last 2 days, they have unstable angina or unstable or uncontrolled arrhythmias, if they have symptomatic severe aortic stenosis, acute pulmonary embolus, myocarditis or pericarditis, and obviously if they have acute aortic dissection, we don't want them on a treadmill. And relative contraindications are things that we would say you have to evaluate on a patient-per-patient basis. Someone with left main disease doesn't mean that you can't put them on a treadmill. Actually, you could do that to assess their exercise response and their heart rate response, and if they develop any symptoms. But if you already know that it's extremely severe and they're symptomatic, you don't need to confirm that they're symptomatic. They have only moderate valvular stenosis. If they have electrolyte abnormalities, you want to make sure they're corrected before you put them on the treadmill. If they come into the lab and their blood pressure is already 200 systolic, you're not going to put them on the treadmill. You manage their blood pressure. You send them to get their blood pressure under control before they come back. They have hypertrophic cardiomyopathy. Those another high risk group that you assess, okay, what is the risk benefit and what are we getting from this stress test if they have mental or physical impairment and they have baseline high degree AV block. There are a couple of papers here that list the absolute indication for early termination of exercise. And we mentioned these before. If they have ST segment elevations in non-Q wave leads, significant blood pressure drop of over 10 millimeters mercury, if they develop moderate to severe angina, if they have central nervous system symptoms, signs of poor perfusion, cyanosis or pallor, sustained ventricular tachycardia or other arrhythmias, including second or third degree AV block that interferes with normal maintenance of cardiac output during exercise. And again, if you have trouble maintaining proper monitoring of the EKG or the blood pressure, and if the subject requests to stop. And these are relative contraindication. They go along the same line as the previous one. So you don't actually have to stop, but you could consider stopping. So if they start talking about increasing chest pain, they have unusual shortness of breath, if they have wheezing or leg cramps or claudications, arrhythmias other than sustained VT. If their blood pressure goes, this circulation paper mentioned blood pressure of over 250 millimeters mercury for systolic blood pressure and 115 for diastolic blood pressure. In our lab, we use 220 over 110 because what happens is that even if you stop at 220, the blood pressure might continue to go up. So you can stop the test when the blood pressure you have a really hypertensive response. So I think in summary, you could use a AAA logo here that I mentioned to remember this. So A, avoid the situation. It goes back to the proper selection of patients and review the indications and the contraindication of the testing and make sure that this is a safe test to do, that you're ready to do it. Feel free to ask for help, okay? Often you would work with experienced exercise physiologists. There are senior fellows and attendings available around. And always be ready, okay? Don't make sure you're there. Make sure you're paying attention to the test. Make sure if someone comes to talk to you about this, you give it your full attention, and so on. So I think with that, you're certainly equipped to handle all of these situations. I'm sure with your prior training, you are more than equipped to do that, and you have all the resources around to ask for help. I'd like to point you to a couple of resources that are available out there on the ASNEC website. There is a series called the Stress Protocol and Tracer series. They were all released a couple of years ago, but they have documents for each of these topics here. This is the exercise stress testing one. This is just the first scan of the first page. And then there is another guidelines, the ASNEC imaging guidelines that are referred to often in this talk by Dr. Hanslova that go over the different stress testing protocols and tracers in this stress lab. And obviously it would be a miss not to talk about the situations we're in 2020 about the COVID. And I'd like to point you to these other two ASNEC documents. We published this during the pandemic, and this one more recently about how labs would work, nuclear cardiology labs would work to reestablish care in the recovery of the pandemic. And there are some good tips out there and how to manage specific situations. So with this, I'd like to thank you for your attention, and I'm happy to answer any questions you might have. All right, guys.
Thank you.
Thank Dr. Skali.